Hey, Dr. Robinson here, longevity medicine expert. And what I've got today for us is a set of labs. And a lot of times people are wanting to know what is it that we're doing? What kind of labs do we check here, either at the Hormone Zone or what we do at the longevity protocol? What are we actually checking for? And then not just that, but what does it look like when I'm actually going through it? So I wanted to give you this real-time understanding of what it is that I do when I'm going over labs with a patient, what those labs are, and then how I interpret it, and maybe some of the things that I would say. Obviously, everything on this particular, for this patient, everything's been redacted, but it is a 54-year-old female, so everyone understands. And so I'm going to write all over this in red pen. This is exactly what I do with all my patients. I turn the labs right around while I'm sitting here at my desk. I have the ability to write upside down. So I scribble all over everything so they can understand it and really, really teach the patient as they go along. So it becomes a really thorough teaching experience for the patient and a very revealing process for them as we go through these labs. All right, so right here at the top, and we never know what we're going to see, but in this particular case, the white blood cell count here was low in this particular patient. What's interesting about this, and we see this, and you can see this is barely low. We can see the range of 4 to 11 for white blood cell count, and she's just barely off there at a 3.9. But it's interesting to note that white blood cell count has to do with estrogen. So estrogen kind of controls the white blood cells, and testosterone controls the red blood cell count that's right there, which in her particular case is good, at least on that. Doesn't mean her testosterone number is good. It just means that that's what influences it. And so back to the white blood cell count being low, it's just very common in menopausal women. I see it very often. And here, all of these here are all other additional white blood cells. And we call this the differential, but what it means is it's essentially the key types of white blood cells. I call these the different types of soldiers in the army. The white blood cell count up here is the total number of soldiers in the army, but down here it's like your corporals and your sergeants and your captains, excuse me, and all of that. And the differential looks fine, but just the total number of soldiers up here are a little bit low. And sometimes when women get on estrogen, it actually helps us a little bit. Sometimes it can be other things. Okay, moving along. But with that said, the red blood cell count, all this stuff up here, and other aspects of the red blood cell count is all fine. White blood cell count, again, generally speaking, the differential is good. Know that sometimes these guys here, the mean cell volume, MCV, mean cell hematocrit, these can be off sometimes in a B12 deficiency. So we'll see there's sometimes either a little bit high or even a little bit low with B12, and we're also often looking at that. But right now, nothing's wrong with that situation with this patient. So down here, sedimentation rate, this is an inflammatory marker. How we tend to look at that, it's a blood inflammatory marker. This number is nice and low, which is what we're looking for. Now, this next thing, and it's kind of hard to see here, but this is a DNA gene mutation that we look for here called MTHFR. It's a methylation type of gene, and methylation means activation of B vitamins. So we're trying to activate B vitamins in the system. And let's go over whether or not this particular patient has an issue. Now, in Sonora Quest here, they will look for, just like with LabCorp, they'll look for two different genes. And fortunately, with this particular patient, no mutation was detected. But I will tell you that now that we've been checking this for a long time, it's really rare to see someone with nothing. We check for, again, two different types of genes, and usually about 80% of the time we're seeing some level of issue. So what it usually looks like, let's say on one gene, I would say there's alleles. That means there's one from mom, one from dad, and sometimes it will have maybe one of the two or both of them. Then the other gene over here will also have a pair, maybe that has one or not. So we can actually see, and even if there's a piece of it that's off, we believe that it is clinically significant, and that a patient should take methylated B vitamins, and that's something that's usually you need to have patients take B vitamins anyway that are methylated, but definitely if they have any issue here. All right, so moving along. We always take a look at iron. This is super common in both men and women, particularly in women. If I'm getting a little specific here on the ranges, I like the total iron greater than 70. It's a 131. This percent saturation, we look at that pretty closely. I like that greater than about 25, and that's fine there at a 39. We also don't want iron too high. That can be its own problem as well. But usually women tend towards low iron, men tend towards accumulating or high iron. But right now, this particular patient, all is good there. Uric acid, this has to do with gout. It also is an inflammatory marker in general. It's one of the reasons why we have this here in this particular patient. She was fine. GGT, now this is a liver function test, and we check this separate from the regular liver functions. And this particular test can give me an idea, aside from the fact that it's a liver function test, it can give me an idea about glutathione. And that's one of the things we're looking for. So when the GGT is high, glutathione would be low. Now, what's optimal for women is 9. This result of hers at 11, it really, frankly, is very good and isn't a major issue. So glutathione is a key antioxidant. Our body makes it. And when, again, when the GGT is really above 30, we start to think it's clinically significant. You can see the range here will go up to about 68. By that time, we think it's a train wreck. And we often will treat with glutathione, among other things. But one reason why the GGT would be high is alcohol. And another really common one is ibuprofen or any type of NSAID, but particularly ibuprofen. So many people take it. So those two things will make the GGT elevate. And so we'll ask them about those things, and they say, no, I don't drink, and I don't take any ibuprofen. Then we're really strongly looking at glutathione. But either way, glutathione can be a really good treatment if GGT is elevated. CRP, C-reactive protein. This is a really distinct inflammatory marker as it relates to the heart. I want to see it optimally less than 1. You can see here what they're talking about in terms of disease risk here. If it is less than 1, they say you have a low risk for cardiovascular disease. So low inflammation and low risk for cardiovascular disease. Once it gets between 1 and 3, they say it's an average risk. And so that's what's going on with this patient here with a 1.4. But really, frankly, a 1.4 is barely off, and we don't really think that's majorly clinically significant. But it could be a little bit better. If the CRP is above 3, we start thinking, high risk. Okay, homocysteine, one of my favorites. I love homocysteine because it's probably one of the best stroke risk markers that we have. This patient is optimal. I like it optimally less than 8. We definitely want it less than 12. Optimally less than 8. She's coming in at a 6.5. So what's going on with homocysteine? Homocysteine is harmful to the lining of your blood vessels. And what we want to do is convert harmful homocysteine into harmless methionine, which is another amino acid. So usually we're having this conversion process all the time in our body, but when homocysteine goes high, it usually can mean a B6, B12, and methylated folic acid deficiency. So if somebody has a high homocysteine, how do we lower it to harmless methionine? We give the patient methylated B6, B12, and folic acid. And that it's pretty linear how that tends to work. It almost always works virtually 99% of the time. 1 or 2 pills of this very special professional version we have of that. It's amazing how it works. And then again, lowers stroke risk. And again, this serves as an inflammatory marker. Okay, moving along. Here's a little bit more about iron. This is ferritin. This is the storage form of iron. Optimally, I like this greater than 70, but interestingly, I want to see it less than about 150 or so. And this patient's coming in at a 122, so I'm saying that's good. So if ferritin's low, there can be fatigue. Often that's related to low thyroid, just general iron deficiency. Okay, so what I was saying here about ferritin is it also serves as an inflammatory marker. So if, again, we want it greater than 70 most of the time, right around that, we don't want it too low because, again, that can lead to fatigue and other things. But if it starts to get well above 150, we start thinking general inflammation. Maybe at the time in which they drew the blood, maybe they just have overall inflammation. And we see this very much in men with really high ferritin. So again, this patient was in an optimal range. What we tend to see with women is very low ferritin. but that's not the case here for this patient. The folate number here is good. That's fine. Again, greater than 20 would be optimal. And also, we would be looking to see whether or not they had the gene mutation that we were mentioning over here. Again, this patient doesn't have that, but if the patient did have an issue with methylation, they could have good levels of folate, but yet it doesn't necessarily mean that they are methylating or having it, the active form inside the body. And again, likely with this patient, everything is fine. Okay, prolactin down here at the bottom. Prolactin is a stress marker. It's a brain tumor marker, and everything is fine. When I say brain tumor, benign brain tumor, something called a pituitary adenoma, a microadenoma that can sometimes be found. It's very rare, but we have seen it before. And that's usually handled by certain basic medications. But prolactin is very commonly somewhat elevated. And the reason we check it, not because we're really trying to screen out for brain tumors, but because we're looking to see whether or not high prolactin is related to stress. And that then high prolactin will lower libido. And that's definitely something around here that we're very keen to. So we don't want low libido at all from an elevated prolactin. And then we would seek and try to figure that out for that patient. Okay, I'm going to come back to this page because I want to talk about this patient's estradiol level. So estradiol is the main active form of estrogen. We call this E2, di-2 estradiol, so E2. And generally speaking, I want to see this between 50 and about 150. And I want it there consistently, continuously. Now, this patient, she had a 36. In speaking with her, she was on a cream that wasn't really doing anything for her. And we see this over and over and over and over again after 19 years of doing this, that creams just do not work. They have this sort of general up and down nature that don't really keep it consistent with either pellets or with injections, small little subcutaneous injections we do as well. That keeps hormone levels consistent over time. So this patient still had hot flashes, night sweats, vaginal issues, memory and focus issues. Everything was still there for her despite the use of this cream. So not only were her levels still suboptimal, and she said when she first started it was even lower than this, so she got a teeny little bit of something out of it, but it wasn't enough to actually make her physiologically normal and to control things. So coming back here, there's another number that we look at. Where is it? Oh no, excuse me, it's on this page. Over here, this is called follicle stimulating hormone, FSH, follicle stimulating hormone. And what I say this is an email message coming from the brain that goes down to the ovaries to tell the ovaries to make estrogen. And you're only allowed 20 email messages in your email account. It's got to be less than 20. So she still had 78 emails. Her brain was not asking for estrogen, it was begging for it. So if the estrogen is low, or estradiol being low, and the FSH is still high, the way it is here, that's because the estrogen is not consistent from the crummy little cream she was on, then you will still see hot flashes, night sweats, sleeping difficulties, anxiety, vaginal dryness. All of that continues to abound when we have not corrected the FSH and optimized the estradiol. Now, there's more to the story here with the estradiol. We check another hormone here called estrone. So there's estradiol, the E2, and estrone, one. So this is E1. And usually the estradiol is converting into estrone. Now, what we found with estrone, it's a breakdown product of estradiol, of the active form of estrogen, and this can increase the risk for breast cancer. I'm not saying that it automatically does, but it's related more so to that. Excessive levels of estrone, not necessarily excessive levels of estradiol. But generally speaking, a younger woman will maintain a natural 2-to-1 ratio of estradiol to estrone. So if this is a 36, fine. That better not be much more than about an 18 or so. But if this is a 28, fine. That better be, about a 56. So you can see she's kind of closer to a 1-to-1 ratio. And we do not see this problem with pellets, and we do not see this problem with injections, with maintaining the natural protective estradiol ratio of 2-to-1. So in this particular case, with this patient, I made the suggestion of pellets. But there's more to that before I actually even made that suggestion to her. What I was looking for here was testosterone. Let's see if we can find that here. They always put these things all over the place. Yeah, I missed it. Let's see. It's not there. Oh, here it is. So here's her testosterone. So I want to see the testosterone be between 70 and 150. So she's coming in at a 13, which in my mind it might as well just be zero. Anything roughly 20 or less, it's usually just not clinically significant. It's not going to be able to help that patient. So her testosterone was low. And testosterone's helping with memory and focus and helping with neurochemicals, so anxiety and depression and mood swings and irritability. It's helping with muscle. It's definitely helping with bone. So we often think that with menopause and estrogen deficiency, that that's the key towards bone health. And I'm not saying it isn't important, and it would be with this patient, but so is the testosterone. In fact, the testosterone is actually building bone beyond baseline, and estrogen doesn't do that. Estrogen just prevents the further breakdown of bone, but testosterone is actually driving growth. So when you put both estrogen and testosterone into the mix, now you've got bone health. I just did a video the other day about testosterone, and we have been talking about testosterone now for almost 20 years for women. It's nothing new to us. It's now becoming more of a thing. Thank God, I'm glad it is. But these people that are now talking about it are 20 years behind what we have been saying, and we've known it's been important for women. And I've had the privilege of treating thousands and thousands of women with testosterone to great benefit. Okay, so yes, we moved forward. This particular patient, she wanted pellets. Again, we talked about the injections. I think she said she had one of her friends that was doing the injections, another friend that was doing pellets. She decided on the pellets. And that's great because both of those forms we have figured out how to maintain the estrogen and testosterone very consistently in an excellent range. Okay, I'm going to come back to this page here. So that's what we did with hormone replacement therapy, the classic hormone replacement therapy for this patient. But there was another hormone here. This is called DHEA. DHEA is a hormone that comes out of the adrenal glands, and this is particularly the sulfated version, and the sulfated version is the version of DHEA that comes out of the adrenal glands, and we're looking for that. It's also a youthful hormone. It helps with libido and muscle and bone. It's heart protective. It's anti-cancer, but it's very much helpful for stress. And that's something we're usually working on down here. It's very similar to testosterone. And I want to see this greater than about 280. I'm happy if it's in the 200s. A 99, once about 100 or less, it's getting pretty low. So usually 10, maybe 20 milligrams of DHEA can be very helpful for patients, and that's what I recommended for her. Insulin, we checked this out. I like this optimally less than 6. I mean, she was at a 3. This was super good. I at least want it in the double digits. Once it starts to get into the 20s, you can see the ultimate range here. Once it's in the 20s, for us, we think it's crazy high. But this particular patient was not obese, didn't have any of those issues, and generally speaking, this is very optimal for her. Vitamin D. So I want to see vitamin D, or what's also called hormone D, because vitamin D operates like a hormone in the body. I want to see this greater than 50, really optimally around 70. She's on 54. She has a 54. She had told me she was already taking vitamin D, and that was great in this particular case. Okay, moving along. I'm going to probably come back to this page as well. So let's come back here. Here's magnesium. Magnesium is really one of the most important minerals that you can possibly work with for both men and women. The older we get, the more we sort of have issues with it. It's just the older, hell, it's with people who are younger as well. It's the number one mineral deficiency of all minerals. And so we watch this very closely. I'm a big fan of the work of Dr. Carolyn Dean. I would highly recommend looking up her work. And what I've learned from Dr. Dean was that really there isn't a good test for magnesium. Largely it is going to be symptom driven. With that said, if we're going to look at a particular lab, we would look at the red blood cell magnesium. You might find regular magnesium, it's serum magnesium. That is a worthless number from a nutritional standpoint. Doesn't tell me anything nutritionally. Red blood cell magnesium is talking about magnesium in the system over 90 days. So it becomes a little more accurate. and we will follow this particular number. Some patients take very, very ample levels, amounts of magnesium, and these levels don't actually always increase, but many, many times it does, many times it doesn't. But it helps to give us a general understanding of what's going on. If I'm getting picky, I like it greater than 6 to be optimal. I'm usually happy if it's in the 5s. It is for this particular patient. Methylmalonic acid, this is actually checking for B12. It's probably the best way to check for B12 status. There's just regular serum B12. It's not going to be as accurate as methylmalonic acid. So the lower the number on this, the better. Again, in her particular case, all of that looked pretty good. Again, she had her MTHFR gene mutation wasn't much of an issue. So this doesn't surprise me that her general B12 was probably good. She was not a vegetarian. So this is pretty straightforward. I'm going to come back to that page as well. Let's go over here. So blood sugar, good old-fashioned glucose. So we're looking for this to be between 70 and 85 to be optimal. 86, she's pretty much there. You can see that the range will go up to 100, and we definitely don't want it above 100. But once it starts to get above 110, they're going to say insulin resistance, which is like pre-diabetes. And if it's above 126, then we start to say actual, diabetes. And so she's nowhere near that, but just know that these are the levels that we're looking at. All of these guys here, this is all like a bunch of kidney functions. All these things were fine. From globulin on down, this is roughly all liver. Again, all of this stuff was good. These are 1, 2, 3 key liver function tests that were all great. Okay, cholesterol. Dastardly and not so dastardly cholesterol, the thing that everyone's all bunged up about. And we have been, pretty much since the 70s and 80s, everyone's been talking about cholesterol and how it's evil and how it is the cause of all of our ills when it comes to cardiovascular disease. I'm not a fan of that literal false hypothesis. It is not that at all. We've got plenty of research now to show that cholesterol levels do not give us this direct understanding of what's going on with someone's stroke risk, with someone's risk for cardiovascular disease, or like getting a heart attack. It's not related. However, with all of that said, I like to look at the numbers. Let's say they are quote unquote elevated. They're using 200. If it is slightly elevated, why? Why is it elevated? Maybe the patient is overweight. Maybe the patient does have blood sugar handling issues that's leading into these levels being high. Of that, I'm going to be concerned, but only because I'm looking at it indirectly, not because I just think that this number in and of itself is going to be bad for them. Cholesterol is actually an antioxidant. Cholesterol helps us to make sex hormones like estrogen and testosterone. It helps our cells to communicate. It's incredibly important for our brain. The list goes on. And that even includes the LDL, which is the so-called bad cholesterol. Even that has been shown as an antioxidant. We call it nature's Band-Aid. It is there to actually try to help the lining of blood vessels. So with all of that said, it just becomes the culprit of things. It's like that's the thing that was standing there at the scene of the crime, and it doesn't necessarily mean it was the cause of the crime, but it was just standing there at the scene of the crime, like the hardening of the arteries. So they blamed cholesterol. So no, but again, looking at it and trying to understand what's going on with the patient, to understand their real situation comprehensively, yeah, I'll look at it that way. But yes, I told this patient, particularly this particular patient, not to worry about these numbers at all. Insulin like growth factor 1, this is about human growth hormone. We look at this very closely. I like this greater than about 150 for women. She was at a 175. This is great. There's argument to say that if IGF-1 is high, that can be an issue. There's argument of it being too low. I definitely think it's a sweet spot. When I say argument, meaning they will say in the longevity circles that if it's too high, that's actually negative towards helping someone live longer. But we also know that if it's too low, it is negative towards someone living longer. So we look at this and just try to keep it balanced somewhere in the sort of middle road of that concept. So right around 150, maybe upwards of around 200 for men, we think is optimal. And it's very relatively simple to improve human growth hormone, whether through peptides or other routes for that. But growth hormone helps with our skin. It's helping with recovery. It's helping with deep sleep. Very, very important hormone to consider. Again, in her case, everything was fine. Skipping around here. All right, let's come over here. Now, she was A positive blood here, blood type. We check blood type often because a lot of patients know and a lot of patients don't know what their blood type is. So we just throw it on there so they can be informed. But here's this next test. It's also one of my favorites. It's called Omega Check. This is looking for essential fatty acids in the blood. Essential fatty acids are EFAs. And those essential fatty acids are the ones that are kind of listed here. The omega 3s, that's all these guys here, and then the omega 6s, and that's all of these guys here. Now, omega 3s, these are the anti inflammatory forms of essential fatty acids. The omega 6s are the pro inflammatory versions. This is the sort of seed oils that everybody's talking about now, thankfully. Seed oils will drive up these omega 6s. And then the omega 3s generally would be the fish oil kind of concept, and which I think is probably one of the best supplements that somebody can take, a high quality fish oil. So, what's happening here in this particular test, her overall amount of essential fatty acids are low. How they're all differentiated, and they do this all by a percentage of weight, and this is all fine. So they're spread out correctly. The omega 3s to omega 6s, all of that is generally good. It's just the overall amount of her essential fatty acids are low. And so we can see we wanted greater than 5.4. She's way down into 3.4. So then statistically, they go through and look at a relative risk for cardiovascular disease based on her essential fatty acid content in her blood. So in her particular case, it was a high risk of cardiovascular disease based on this. Again, not necessarily the cholesterol, but we're talking about her anti-inflammatory good essential fatty acids and all the things that those do for the lining of our blood vessels, keeping again the inflammation down, what it does for our brain, so many different things. So her relative risk there was high. Now, what's the fix for this? By the way, just simply take fish oil. We have seen if we give them a high quality professional version of fish oil at the right dose, these numbers go up. It's really not very complicated. 3 to 6 months, we'll see this change very easily. It's quite a linear response. So taking fish oil is important for almost anybody, but it's nice to see your levels. Okay, here's a little summary page. I think what was this guy here? Yeah, here's her zinc. This is red blood cell zinc. So where we were talking about red blood cell magnesium, here's the version for zinc. I actually like this greater than 11 on this particular scale. She's at 11.2. I thought that was probably okay. We do another test called a zinc tally test. It's actually liquid zinc we have the patient taste. And if it's really gross, then they usually have very good zinc levels. That test is not perfect, but we throw that test in too. So between her zinc tally test she did plus this test, I didn't think zinc was the tree to bark up for her regarding her nutritional needs, and likely she's getting pretty good amounts in her diet. So that's the zinc. This is a summary page. A little bit, okay. So now I want to come back to, and I'll save the best for last year, thyroid. And let me see here. Here it is. Okay. So right there, TSH, thyroid stimulating hormone. Now, letting everybody know too, just in general, both the books that I've written are for thyroid. I've obsessed on this for almost 20 years. I think that people are underdiagnosed and they are undertreated when it comes to thyroid hormone. The conventional approach is just generally wrong. It is maybe okay, but most patients will do better when they have a more comprehensive approach, when they actually can get their levels driven up to where they're optimal. And again, conventionally, they don't look at many things that we look at, and they don't really get themselves concerned with driving the dose, and they don't really concern themselves with giving a patient T3, and T3 is the active form of thyroid hormone. So TSH, my optimal range here for this is 0.3 to 2.0. Now you can see over here, they're allowing it to go all the way up to 4.2. The higher the number goes, the more low functioning the thyroid is. This one's opposite of what you think. So again, the higher the number, the lower the function. So 0.9 being on the low end is actually optimal. And again, she's within this range, my optimal range. So the other thing is we looked at T3, the free T3. I want to see this greater than 3.1 And there she is at a 3.2. So that's pretty good all in and of itself. And again, you can see this very broad range. They'll allow it to go down to a 2.0 and say that it's okay. I wouldn't think that. Okay, so that's good. And then, let me see. Here are two antibodies. So what I'm looking for here is an autoimmune condition called Hashimoto's. So Hashimoto's thyroiditis, again, it's an autoimmune condition. We're seeing whether or not maybe the immune system is hyper reactive to thyroid tissue, and that can cause all kinds of problems. Now, in her particular case, I checked two antibodies. The thyroid peroxidase antibody here, that's, first of all, most doctors don't check it at all. If they check, they will only check this one, and they usually don't check the thyroid globulin antibody. We routinely check both, and both of hers are nice and low. That's what we want to see. So I do not think that she necessarily has Hashimoto's, but I will tell you that some patients still can have Hashimoto's even though these numbers are normal. And there's been studies where they've shown that, where they've actually looked at the gland itself under the microscope, take a sample from a patient and see the autoimmune thyroiditis inflammatory reaction of the thyroid gland tissue, even though these antibodies are normal. So I always take that with a grain of salt, and it depends on how the patient presents. We might actually think there's still a Hashimoto's situation going on, even though these numbers are negative. But I would say generally it kind of correlates and is helpful. Okay, so that's more. I think there's a couple more things on thyroid. I'm done with that. Oh, here we go. So free T4 and total T4 here. And the free T4, I want to see this greater than about 1.2. It is at a 1.4. And the total T4, I want it greater than about 7. And there she is at a 7.6. So this is largely, T4 is largely telling me about production of thyroid hormone, and her production seems to be pretty good. The T3 portion that we talked about over here is she converting her T4 into active T3? And again, I think in her particular case, she was. Selenium, zinc, iodine, these things are all important for that conversion, magnesium. So all of this looked pretty good. We had some additional tests that I did with her for her thyroid, some physical tests that we did in-house. Those also looked pretty good, and we didn't really think that this was an issue for thyroid. We look at it all very, very closely. So that's the whole thing. Did I go over everything? I think oh, no, I missed one. This is reverse T3. So this is the final number here, and it's the final number we will look at when it comes to thyroid. So her total T3 is the active form of thyroid hormone. It increases metabolic rate. Reverse T3, this lowers the metabolic rate. And I want to see this less than 11 if I'm getting picky. She was a 16. It was on the edge. And what makes the reverse T3 go up? Stress. Cortisol is the key hormone that will make this go up. And so a 16 is not bad. Once it starts to really get into the 20s, it can be an issue. Even that stress, by the way, can be mental, emotional stress. It could be the physical stress of calorie deprivation. Sometimes when patients are just not getting enough calories, let's say on a GLP-1 like semaglutide or tirzepatide, you'll see the reverse T3 actually go up, and that lowers the metabolic rate. So we don't want to see that. And anyway, it will, if the reverse T3 is high and the T3 is good, then that could mean that there's still a potential thyroid issue there for that patient. But again, things for her, I think, were fine. But you can see how detailed we are, and we're going to look at each individual case. So even these numbers in themselves aren't always exact, in the sense, exact meaning my interpretation of it might be different based on the human being sitting in front of me and the overall clinical picture and what symptoms they're telling me, what their past medical history is, what their family history is. All of that's going to play into what I'm looking at here. So I'm looking at optimal levels, and I'm looking at the human in front of me. And this is what we do. I go over this kind of lab. I might go over something that maybe 5 to 10 times a day, this particular, what I just went over here with you. We'll do it with new patients. We do it. We also check this detailed set of labs, at least on an annual basis with patients, to really always do a deep dive and see how they're doing. So know that when you're coming here, you're getting a comprehensive approach. And we always, as we always say, we look forward to serving you.